right, I think we can go ahead and get started. Thank you everyone for joining us for the second event in our Heart Month series. Today we are thrilled to be joined by Dr. Mohammed Irfan Ali, a vascular surgeon here at Bay State. And the topic of today's presentation is Beyond the Blockage, Transforming Peripheral Artery Disease Treatment. So we thank you all for being here, and we thank Dr. Ali for being our presenter today. And with that, Dr. Ali, I will turn it over to you.
Well, good afternoon at this point to everybody. Thank you guys for being here. I know it's going to be a busy day. Best of luck for those that are Patriots fans. It should be a good game. So to that end, my name is, as said, Mohammed Irfan Ali. So I'm one of the vascular surgeons here. I have fortunate enough to be part of a very large group of outstanding clinicians as well as vascular surgeons here at Bay State. So it's my privilege to go through this presentation with you guys. I have no disclosures. And to that end, a line that always kind of resonates with me is, especially when it comes to things like heart disease and peripheral vascular disease, and really anything where we can do things to sort of improve upon our health to make it a little bit better for ourselves and those around us. Try to be the change that you want to see in the world. I think it's a pretty good line. So getting right to the talk, I do have a couple of pages of objectives, and don't let it necessarily scare you away from the information. I'll try to keep it as linear as I can. But there's a lot about peripheral arterial disease. It's sort of an underappreciated healthcare burden in the sense that there's a lot written and there's a lot that has been done, but it's not really particularly well understood amongst the population. So my goal is to give you a little bit of history and to give you an understanding about the disease burden. Also to sort of define and recognize peripheral arterial disease as a disease burden on healthcare in general. I'll go through some of the risk factors and some modifications that are easy to discuss, sometimes harder to implement, and then some of the role of management in routine PAD. Beyond that, then I'll also, discuss the diagnostic approach for peripheral arterial disease, and then treatment that's just beyond medication and sort of conservative therapy, and then talk about a little of the complex endovascular techniques and open revascularization techniques that we have available to us, especially when medications and the normal things that we talk about in the office do not cut it. So every single question and every single thing that we talk about within vascular really comes down to really the why. What we sometimes understand what it is that we're talking about, and we understand sometimes how it actually comes to be, but why is peripheral arterial disease actually as big of a deal as it is, to the point where I'm making the presentation today. So peripheral arterial disease, it's a progressive disorder. It is not something that you can necessarily reverse. But the reason it happens is that you have an accumulation of fat, lipids, and then from there, the lipids themselves, your body attacks, turns into a plaque. And that plaque eventually turns into something that either hardens or narrows your blood vessels. And I have this little diagram right here that really kind of goes through the whole progression of just a initial lesion to something that's, otherwise reasonably normal, but a little bit of thickened, all the way to something that becomes complicated, that comes into a plaque that ruptures or causes a problem, whether it's a pure blockage where it's 100% block, or it leads to a plaque that travels. And so the easiest way, and I think the simplest but most effective way to explain this, is think of your leg arteries, especially, as plumbing in an old house. So over decades, you can have plaque build up, and eventually, as these pipes start to have rust and sludge build up into it, you eventually have a point where the pressure drops. And if the pipe eventually clogs, then the actual pipe itself will not feed what it needs to go to, which is the foot. And that's where we start having pretty significant problems. And so as far as the actual scale of the problem, it's not just the people that we take care of within Springfield, and it's not just something within the United States exclusively. It affects a lot of folks globally, and it's usually underdiagnosed as a part of the normal aging process. And the bigger problem with peripheral arterial disease, it's not just a problem with your legs. It most commonly affects your legs, but it also is a pretty powerful marker to show you there are other problems elsewhere within the body. Coronary artery disease is one example. When you have narrowing of the carotid arteries, that can lead to stroke risk factors. That's also another thing that, this is a marker for other problems that may happen elsewhere in the body. So to that end, the actual reality of the matter is, what does this lead to? And the eventuality is that this can lead to, pretty significant morbidity, whether you're talking about amputations or mortality in and of itself, to the point that if you take a look at the mortality risk of peripheral arterial disease and the end stage of it, the 5-year mortality rate is more than breast, colon, or prostate cancer combined. And just to really kind of drive it home, if you take a look at this pretty decent paper that was put out about 5 years ago that looked at the comorbidities and a lot of the things associated with peripheral arterial disease and the end stage of what this leads to, which is minor or major amputations, as well as in some cases with diabetic foot infections. You take a look at right in the middle of this schematic, all cancer in terms of 5-year mortality was just about 25-ish%. Whereas if you take a look at, those that have minor amputations, chronic limb-threatening ischemia, that's somebody that's had peripheral arterial disease that has developed collaterals, but eventually gets to the point where they're not able to walk as well as they want to, or those that have had major amputations, their mortality at the 5-year mark is so much more than just all cancer combined, with the exception of lung cancer. So where does that sort of leave us? I see your question about difference in peripheral arterial disease and chronic venous insufficiency. So the simple answer there is that the veins and the arteries are two very separate systems. So the arteries are the vessels that come from your heart and actually lead to everywhere else in your body. So it's basically like the highway away from your heart, getting oxygen and blood to your feet, to your fingers, to your brain, to all of your other vital organs. Whereas the veins, that's the highway that brings all the blood on the way back. Chronic venous insufficiency is a problem in and of itself, and that's a whole topic I could talk about at some point in time later on. But that's a problem where the actual veins do not allow for proper return of blood flow, so they pool in places where they should not pool, such as the feet, calves, and thighs. So that's a good question. So as far as risk factors, there are a lot of risk factors that we can modify that we know of. There are certain things you cannot modify. You cannot, necessarily modify your age. You can't necessarily modify your genetics. However, one of the big things that we will talk about, smoking, you can modify. You can always modify your weight. You can always make sure that your diabetes is better controlled. Make sure that your blood pressure is better controlled. We talk a lot about, things in the office when, especially the patients that know me pretty well, talk about your cholesterol medication. These are all things that contribute to the actual, the formation of these plaques within arteries that actually lead to bigger and bigger problems later on. And so in the spectrum of peripheral arterial disease specifically, it ranges in terms of how it actually affects you. And so whenever I talk to, like my folks in the office, we talk about, is there peripheral arterial disease? It's either a yes or a no. And if there is, how much is it bothering you? And so the range of it is, it can be asymptomatic where, there's a blockage, but you've sort of developed internal bypasses where your body's found a smart way to develop, alternate highways, alternate pathways to get blood to where it needs to go. Then there are those that come in that have muscle cramping, fatigue. Is this something that has gotten to the point where as you walk, you have to stop at a certain point? And we talk about, how long are you able to walk before you need to stop? How long are you able to walk before it hurts? And so that you can look at this sort of like as angina of the legs, if you want to sort of put, two concepts together, the heart and the legs, because really in reality, it's a similar concept. If you don't have enough blood flow, then it hurts. Now you start getting to the point where it hurts all the time, or you start developing wounds, or you start getting gangrene where your toes turn black. And so those are difficult discussions to have, because at a certain point, that's where you really have to sit down and think about, what do I need to do to help this patient out? And what do we need to do to solve the problem? Some cases, where we talk about, just burning pain at night, there may be a deft solution. We talk about a bypass, or there might be something more advanced that we can do with just wires, catheters, and balloons. But when we talk about ulcers, these are things that are starting to threaten the limb, or gangrene, where effectively there's no arterial blood flow to the actual end part of your leg. And that becomes a huge problem in terms of, well, we have to get blood flow there. And now what else do we need to do to make sure that this doesn't turn into an infection that'll threaten the limb even further? you can take a look at this as kind of like the heart attack of the leg. We have to carefully plan what we're actually going to do to help those patients out. In terms of the anatomy, so you can really divide it into three separate segments. And whenever we, as a group, talk to our patients about where the problem actually may lay, we talk about the inflow. So that's the highway where the blood is going from the heart and it's trying to distribute to the rest of the body. So that's usually the aorta and that's the iliac arteries, especially when you're talking about the lower extremity. Where we start talking about outflow, or sort of like the main sort of road that kind of goes to other parts of your limb, that usually starts right at like the hip, right where the femoral head is, and that's where we have the common femoral artery. So the femoral artery is both the deep and superficial, as well as the popliteal artery. The superficial femoral artery is one that we talk about often because it's the one that is the most common site of blockage, right before you get to the popliteal artery below the knee. And in certain patients, when we talk about like diabetics and those that have kidney disease, end stage renal disease especially, you start getting problems below the knee. And these are the tibial arteries. And we talk about it all the time as part of our exam. You know, we have our little Doppler machine and we say, all right, well, we're going to listen to the signals because we can't feel the blood flow at the feet. Once you can't feel the blood flow, you have some level of peripheral arterial disease. How bad it is, well, that's where further studies are sort of needed. And so the runoff vessels, these are the ones that are going to the individual parts of the leg. These are the tibial vessels, the one that's on the top of your leg that goes on the top of your foot. That's your anterior tibial artery and the dorsalis pedis. The one that's on the inside of your ankle, that is the posterior tibial artery. And the one that runs right in between the bones, actually one of the more important vessels that lead to, blood flow down to your foot. That's called the perineal artery. And we have ways of assessing all of those with our Doppler machine. But then we go one step further from that. We understand now where the blood is coming, where it needs to go. But how do we, come to the point where you come to the office and you see us and we figure out where the problem is or how bad the problem actually is? So we do this thing called the ankle brachial index, which is not always as well explained or understood by those that are coming in. And so just to give you a simple explanation, and this is the criteria we use when you take a look at an ankle brachial index, and this is how you actually do it, where it's a blood pressure cuff in the arm, it's a blood pressure cuff at the ankle. Your arm, especially the brachial artery, the blood pressure at your brachial artery is about the same as what it is when it's coming out of your heart going to the rest of your body. That rarely changes unless you have a blockage, somewhere closer to your heart, which is not common, not really in the scope of what we're talking about. But because your legs, it's fighting gravity, and because they're usually the side of where you have a majority of your problems with blood vessels when you come to PAD, if there is a problem at your ankles, you will see it, and that's a ratio. So the ratio of how the blood flow is going to your ankles compared to your arms, that's the ankle brachial index. So above 0.9 is considered normal, less than 0.9, that's considered diagnostic for peripheral arterial disease. And we start getting values below 0.4, that's where you have sort of a state where there's constantly less blood flow than what you actually need at the feet. And then there's kind of an important disclaimer, a caveat, if you will. In diabetics especially, you can have calcification in your blood vessels that artificially increase the actual value itself, may falsely elevate, may have a false sense of security as to what the value actually means, whereas in reality, in diabetics, we get a lot of foot ulcers or may have other wounds or may have symptoms despite numbers looking normal. You still have to sort of do other things to examine where the actual issue is. And so when we take a look at this, and these aren't true ankle brachial indices, these are both what's called like multi-segment. So they look at blood pressure at different segments of the blood vessel from the femoral artery all the way down to the feet. But if you focus right at the bottom, right where the ankle pressures are, on the left side of your screen, you'll see the dorsalis pedis and posterior tibial vessels and the pulse volume recording, as well as the actual pressure right at the ankles. You'll see that they look the same here at the bottom as they do around the femoral artery. Whereas if you take a look on the right side, which is an abnormal study, you can see multiple areas, especially on the right leg, where it is abnormal on the right leg compared to the left. And so this is, some of the data that we take a look at in the office, and we take a look at the ratio. You see right here, like at the popliteal artery, 0.58 is the value here, or down by the feet, the value is 0.56, 0.54. This is considered abnormal compared to the other side on this patient on the left, where everything here is 1.98, 1.99. So this gives us an idea that there is an issue, and this gives us the opportunity to investigate a little bit further to figure out where the issue is. And that's where we start talking about ultrasounds, and we talk about other things that are non-invasive to figure out where the issue is. It's usually the first line imaging where we do an ultrasound where it's just a probe. It looks at the actual anatomy of the vessel, it looks at the actual blood flow within the vessel. And then sometimes we can combine this with a Doppler function where we can hear the blood flow along with seeing it. So healthy blood vessels have a characteristic sort of sound to it, and triphasic sounds a little bit like a drum beat, and it's things that we've been trained into to hear, understand, and we evaluate it kind of every day. We know what normal sounds like and abnormal sounds like. Whereas monophasic, if you think about, back to the pipe analogy, where you have a lot of narrowing, you have a lot of sludge. The rhythmic sort of sound of what blood flow should sound like has been reduced to something that's just kind of continuous. It just sounds like, there's fluid that's flowing, but it does not sound normal. And then kind of giving you an idea of what we look at, because you guys see values and you see numbers and you see papers that have a lot of words. All of the surgeons within our group, as well as the clinicians, those that help us out in the hospital as well as in the office, we look at the pictures and we evaluate the actual pictures as well as the values and put together a story that we can use to help you. And this is what it looks like. Whenever we look at an ultrasound, this is a picture of the superficial femoral artery in a patient. It shows us the actual speed, and it also shows us, you know, other factors within that ultrasound. Is there calcium there? Is there narrowing there? Are there other things that we're missing that we wouldn't necessarily be able to see just with the ankle brachial index? And once we get to the limit of what the ultrasound can do, that's when we start talking about CTAs, as well as in some cases for certain patients, like, MRIs. And so angiography. So these are modes still non-invasive, both the CTA as well as an MRA that uses contrast in some fashion. So CTA uses iodine-based contrast, whereas MRAs use gadolinium-based contrast. In both cases, they're high-resolution images. CTAs are better for seeing calcium. MRIs are better for seeing, soft tissue and kind of like an area where smaller blood vessels may lay. They do run their own risk, and there are things that we have to consider whenever we order them. For instance, the iodine in the contrast that's used for CTAs can affect kidneys if we're not careful about hydration and worrying about the kidney status. Whereas, MRIs, like the big risk there is if you have a metal implant, whether it's a implant for the heart, or if you have other metal that's not compatible with the machine, you can't do an MRI. And that really leads us to the gold standard. So, once the CTA and MRI are considered and suppose they give us information, ultimately we do angiography, and that's an invasive study, and that's where we are able to access blood vessels. We're able to use a wire and needle catheter and then be able to get into the blood vessel and put a catheter within your body to actually get similar information. And the real advantage of doing any sort of angiography is not only does it give us information of the blood vessels, but it gives us the ability to diagnose and perhaps treat if it is indeed a thing that we can do. And to give you as a way to sort of see all three side by side, the MRA is all the way to the left, and that's the MRI that does not use, contrast that's not quite as harmful to kidneys in certain patients, versus the CTA, which, uses a dye but gives you a better idea as to where the calcium is. Whereas, there are gold standard, which is an angiogram. That's the third image right here. You can see that the images are similar and they all have useful information. In practice, really, we do a lot of CTAs because we want to see the calcium burden. And then whenever we do angiograms, that gives us, an idea when we see the calcium burden, especially within the aorta, combines it with what are we able to see dynamically within the angiogram itself to see what we can actually treat. So going from there, what we also want to, kind of put together. So we've given you some things that we have used to evaluate peripheral arterial disease and some of the imaging modalities that we can use to see where the actual problem is. But what does it really mean for us when we first see you, and things that we can kind of do? Why not use an angiogram for CT and MRI? But why not use just an angio versus the other non-invasive studies? So When we evaluate in the office, the biggest thing that we sort of want to know is, number one, in certain patients, we always check your femoral pulse. So if we can feel a pulse in the groin, it's usually a good sign that that's a vessel that we can access, that we can use a wire catheter and needle to actually do the invasive study. But you have to really worry about in certain patients, if you can't feel the pulse, or if you know that their disease burden, if they have a lot of calcium, are you going to do more harm than good? And that's kind of a little bit more of a loaded question in terms of our approach. It's not just a matter sometimes of just putting a needle in place. It's not a benign procedure doing an angiogram, because you have to be able to access the vessel, do the study, and then do what needs to be done, whether it's diagnostic or if it's actual therapeutic intervention. But if it's a femoral vessel that in and of itself is pretty calcified, sometimes what is actually necessary is to clean out that femoral artery and then do the angiogram after you've cleaned out the femoral artery. And that kind of gets to what's called a hybrid procedure, which I'll get to in a few slides. But that's a good question. You usually, unless you know and you have a good index of suspicion that you can fix it with just one go with an angiogram, sometimes a CTA gives you good information with your iliac vessels in the aorta, things that you can't access or see or fix easily without better imaging. So that's a good question. So the biggest risk factors. So again, smoking, we talk about it time and time and time and time and time again. It's never a judgment. It's just a matter of what is the reality of what smoking does between the chemicals, between the nicotine, and then the fact that this necessarily will make things worse once we actually do what needs to be done in terms of our interventions. Smoking is not just bad before, but it's also bad after the fact. Suppose you continue smoking after we help what we can help as far as your peripheral arterial disease. Diabetes is the same way. The better we can do about controlling our diabetes, the better it's going to be in terms of limiting the amount of damage to the blood vessels that there is. Same thing with hypertension, hyperlipidemia. The thing about age and genetics, these are things that we just cannot change. Unfortunately, sometimes we are given the cards that we are given, and we work within the confines of what we actually have. But as far as smoking cessation and in terms of why it's such a big deal, multiple studies over multiple years have shown that smoking triples your risk of failure, not only before intervention, but even after we do anything in terms of either a bypass or endovascular interventions. And so where does that really lead us? It really increases your risk of an amputation. If you go back to the first couple of slides that showed you the ultimate thing that really leads to morbidity, mortality within patients that have peripheral arterial disease, once you start crossing down the path of, well, we have to talk about there's nothing else we can do, then once you start talking about amputation as your end sort of target, well, then the quality of life goes down, and then some of the things that we want to do to keep you healthy, it becomes a bit of a challenge. And this is the reason we harp on smoking cessation as much as we do. Likewise, as far as diabetes and hypertension, there are guideline goals by by the endocrine folks. Diabetes, you want to keep it below 7, and then the American College of both internal medicine folks as well as the family medicine folks have shown that you want to keep your blood pressure between 130 of below 130 over 80, just to kind of make sure that you're not stressing the vessels as much as possible. How long does it take? So another question, how long does it take for changes to lifestyle to impact blood flow? Are changes ever enough to hold off advancement of disease? That's actually a fantastic question. So for changes to impact your lifestyle, smoking, so the most current studies say, suppose you stop smoking right now. Suppose you've been smoking for 30 years, and we say, today's the day, we're done. Within about a month, your lungs and then the actual tissue inside your lungs will start to remodel and will start to expel a lot of the toxins and a lot of things that have been damaging them for years and years and years. Once you get to 3 months, you'll start making brand new cells inside your lungs, and a lot of the toxins and a lot of the things within cigarettes will start to dissipate from your body. Once you get to about a year of smoking cessation, you don't necessarily reverse anything, but you've arrested that sort of rapid decline to the point that once you get to a year to 5 years, you've essentially modified your risk factors to the point where you're about as if you had not smoked for the past 10. And so the longer you step away from smoking itself, it doesn't stop what's already been done, but it prevents you from advancing at sort of like, a runaway pace, that you would have been on that path otherwise. So it's high risk of scar tissue, maybe it's soft tissues or hard tissues. So I was reading your question. It was high risk of causing scar tissue. Tell if it's soft tissue or hard tissues. So kind of depending on what you're talking about, especially when it comes to blood vessels specifically. So the scar tissue in and of itself is typically a combination of your platelets aggregating and then causing the inside of your blood vessel to become really thick, as well as plaque developing where you have calcium, where your white blood cells are attacking that plaque. Um, that's a good question to ask because that kind of leads to what we're talking about right here. The reason we talk about scar tissue on the inside of blood vessels and preventing blood vessels from getting worse than where they are right now, it's really platelets. Platelets are usually culprit as far as what is causing the biggest problem within blood vessels because platelets really try to aggregate. They try to gather around places where you know that the body knows that there's damage. And so the reason we also talk, in addition to controlling your blood pressure, diabetes, as well as your lipids, we talk about aspirin and Plavix. I know those who have seen me in the office I always ask the same question: Are you taking a baby aspirin? Are you taking a statin? So beyond the LDL, aspirin really helps to prevent platelets from aggregating from inside the blood vessels to areas that are already damaged. Aspirin has about a 20% sort of inhibition, whereas Plavix or clopidogrel has about a 70% inhibition. More contemporary, so newer studies have actually shown that, especially within peripheral arterial disease, that if we add this drug, it's actually typically at higher doses, it's an anticoagulant, it's a blood thinner. At lower doses, 2.5 milligrams, whereas its normal dose is like, between 10 and 20 milligrams, you add Xarelto to aspirin, you significantly reduce acute limb ischemia or like blockage or loss of limb or loss of blood flow to that limb, as well as events that could damage your heart as well. So it's been proven to actually be a very useful and powerful drug. Now, we have to be sort of careful about the way that we go about prescribing and kind of going down the path of what this trial is dictated. And there have been questions that have been answered to that end for those that are sort of higher risk, patients that are older, 75 years or older, patients that have kidney disease, patients that are, chronically malnutrition. And it's been shown that even those that are considered medically fragile, you can safely do, the things that are described in the Voyager trial with Xarelto and aspirin with good evidence of pretty decent effect. A lot of us still do aspirin and Plavix for other reasons, especially depending on what we have within our interventions, especially when it comes to like stents and stent grafts. But this is just, sort of food for thought when we have this conversation with you guys in the office. All right, let me see. There's one more question. And my pleasure. We appreciate it. Would you recommend any other diagnostic tests for a 71-year-old male? The calcium score, low blood mouse bone, negative stress test, or laboratory? Yeah. So usually, and with anybody that has no other significant risk factors, like I said, sometimes simple is better. Sometimes seeing us in the office, if there is any sort of issues with your walking, or if there's anything that really leads us to do an ankle brachial index, those are the biggest things that are the simplest, most effective ways to sort of screen, if you will. But in the absence of, any problems walking or any wounds, you know, there's not really much that I would recommend empirically unless you start needing to have, us evaluate you within the office. So the coronary calcium score, I do sort of caution, it's a reasonable tool. It gives you an idea of like how much calcification there is within the blood vessels within your heart. And yes, that can give you an idea of what else is going on within the body. I don't know how to necessarily always correlate that with things that we see within the office. Those that come to the office have problems walking, or they have wounds, or at a certain point they say, well, I have to hang my feet off the bed so that they don't hurt anymore. So that's usually why we see you in the office, but it seems like you're doing everything else that you need to be doing to kind of keep yourself as healthy as possible. And how about nitroglycerin? Is it only a short-term solution, or can it be beneficial for expanding the blood vessels? So nitroglycerin is typically one of those drugs. It's typically used for those that have angina of the heart. We use it sometimes as a chemical when we're trying to get really small blood vessels open when we're doing bypasses It's used locally. It's a very short-acting drug. We're talking on the matter of seconds. It's not a great long-term solution. That's like, going to a really clogged pipe and taking like a pipe cleaner and opening up just a little tiny like, bit of that pipe and hoping that things are going to be normal. So some of the things that we talk about here in terms of lifestyle modification, as well as medications to help with modifying what's going on, that is actually the better long-term solution. Whereas nitroglycerin, that's usually a rescue therapy for those that are having heart problems specifically. So in terms of your goals of where you want your LDL cholesterol, that's the bad cholesterol, or in the US, we define it as non-HDL cholesterol. So these are European guidelines and the US guidelines side by side, and they're effectively saying the same thing. Whenever you go to your primary care or if you go to cardiologist, you want to keep your non-HDL, so anything that is not good cholesterol, you want to keep it below 130 because that limits the amount that's circulated within your blood. So that's why we talk about statins. So Lipitor or atorvastatin or rosuvastatin, which is Crestor, are the typical drugs that are considered high intensity statins. They're very effective of clearing your blood of this cholesterol. But if these goals aren't met, then we add certain things like fenofibrate, or we talk about, the newer drugs, these immunomodulators. It's called Repatha is the trade name for it. But this is a very good, so the PCSK9 inhibitors are actually excellent at reducing your cholesterol burden. And this particular drug, Repatha, actually, without the use of statins, reduces your total cholesterol burden by almost about 65%. So it's actually an amazingly powerful drug that is being used nowadays. So we've done everything in terms of talking about what we do to evaluate you. Some of the things that we talk about in terms of modifying your risk factors and your lifestyle so that we can give you the best chance possible. But where does that sort of leave us in terms of what we do after that? What are the other things that we do? And so one of the things we talk about, and I know there's always, a level of skepticism whenever we talk about, well, we want you to walk more. And I'll give you evidence and I'll show you some things that kind of give you a little bit of focus as to why we say we need you to walk. And we know it hurts when you walk, but ultimately, whenever I talk to, my folks, whenever I see you guys in the office, I always say, whenever we talk about an endovascular or an open intervention, we are starting a clock. And that clock is always measured in 5 years. If we do anything, suppose that you're 65 and we do a bypass, if that bypass is open at 70, then you are within the 68, 60 to 68% of folks that have a bypass that is open, which means there's always a 30% chance of failure. That being said, and that is universal for everyone, no matter who you are, even if you have the best lifestyle modification, even if you've lost weight, diabetes, your A1C is 6%, blood pressure is great, you're taking all your medications. That's just the nature of what happens when we manipulate blood vessels. They don't like to be touched, whether you do it, whether it's been done by itself by the disease, or we manipulate it and we do a bypass, or we do some sort of balloons, or we do some sort of stents. Ultimately, what's been shown is for claudication, especially those that it's not lifestyle limiting or those that don't have rest pain or that don't have wounds, walking therapy actually outperforms stenting in the end. And the real reason for this is when you start walking, especially when you have a blockage, and if you can tolerate it, the more you walk, your body has found ways and it has novel mechanisms within your body to actually force it to grow new blood vessels around the blockage itself. And there is some outstanding studies that have been done over the years. This one was published in 2021, where those that have a meaningful improvement after supervised exercise treatment, this is, a regimented program, not just something where I say, I'm going to go walk for, 500 feet or, like half a mile and then stop. If you actually have a supervised regimen where you walk and you increase the amount that you walk, those folks actually have an incremental and a significant difference in improvement in their overall lifestyle, to the point where once you are at a point where you can sort of beat the pain or learn to tolerate the pain, you have pushed back the time that we're going to intervene. Thus, you are not starting a clock that we don't necessarily want to start. And so when it comes to those that we intervene upon, we try to treat the patients and not just a bulk picture. So all the numbers, all the figures, all the things that we discussed and showed you, those aren't things that we say, these are hard, steadfast, where you pass a certain threshold, let's go ahead and treat it. Not everyone's the same. And then when we, evaluate as time goes on, we're not just saying we don't want you to suffer. We want to make sure that we give you the best shot. But there comes a time where you have, lifestyle limitations with your claudication. And that's when, when walking prevents any sort of like basic routine duties, like work duties, home duties, and then all the medications that we've given have not helped. That's when we talk about, well, maybe something needs to be done. And then at the other end of the spectrum is chronic limb-threatening ischemia, or CLTI. That's when you have rest pain or tissue loss, and that always requires an intervention to save the limb. So when we talk about any sort of like functionality or sort of improvement with anybody that has any sort of intervention in those patients specifically, there's an improvement in those that have had those symptoms where we've actually intervened upon, and that's the reason we continue doing it. Anybody that has intermittent claudication, it becomes sort of a subjective nature. Sometimes you're unmasking and improving upon certain things within those that really we could maybe push a little bit further in terms of their walking therapy. But those that have chronic limb-threatening ischemia, that have wounds, that have ulcers, those patients improve, but you're also kind of, playing a bit of a balancing act in terms of trying to make sure that you improve upon their disease. Sometimes these patients are pretty frail. There are things that we can't necessarily always help. Sometimes they have heart problems, lung problems. They have other issues that they're dealing with, along with a pretty bad disease within their legs. But overall, anything that we do with improving upon their, activities of daily living, their overall sort of depression that may come with any of these issues, and their anxiety that goes with these issues, I think we do a pretty meaningful thing to improve upon those patients. But what we often see with these patients is some of the things that we keep on harping about. We do an intervention, we improve upon things, and you still do the one thing that I will forever and ever, I will die on this hill, say, please stop smoking. Here's the reason we say it. We talked about the risk factors and things that lead to what got you to into the office in the first place. But suppose we do a bypass, suppose we do a stent, suppose we improve upon things. How often these things stay open? Suppose we do a bypass. Primarily, if you continue to smoke, then at the end of the day, you're talking about only 50% of those bypass, any of those interventions at 2 years remain open versus 60% if you don't. Suppose that we go back in, we say you're smoking. All right, there's a simple fix. Let's go ahead and fix it. Even after we assist and we do things to help that, bypass or that intervention, only 60% compared to 75% that have modified and stopped smoking. And at the end of the day, you're talking about overall survival. And it may not look like a big difference in numbers, but we like sit there and expand it over millions and millions of people. There are so many folks that at 10 years do not ultimately benefit because we can't kick the habit that has gotten us sort of to the place where we needed to intervene in the first place. So that's why we talk about a lot of these things. Let me take a look at questions that have come up. So who has a hard time with walking, also has neuropathy. Those are all things that unfortunately agreed. That's unfortunate that legs are swollen, diabetes, hard time walking, and neuropathy. These are all things that unfortunately kind of come with the disease. These are things that hopefully you can take some things from this this presentation and this talk and kind of talk to him about things that maybe that can be changed, and hopefully that we can help overall. Anything that we can do, we'd be more than happy to help as a group. Superficial blood has a family history of blood clots. So baby aspirin has been shown to be pretty beneficial for those that have gotten to a certain age. So anybody over the age of 65 should be taking a baby aspirin for its overall benefit. Superficial blood clots, that's one of those things one would have to wonder why you got the superficial blood clots in the first place. It's not going to hurt anything. But if you have a family history of blood clots, I would really recommend you see, your primary care, and you should probably talk to a hematologist, honestly, for blood clots in general. That's a little bit of a different animal altogether, but that's a good question. But an aspirin's not going to hurt in that case. Are there other forms of exercise, swimming, biking, as effective as walking? Absolutely. So swimming, if you are able to swim, or if you're able to bike, these will give you a little bit better sort of mechanics. It won't hurt your joints quite as much. Swimming especially is, if you're able to swim, about 500 meters. That's about as good as running like a half marathon or was it like a 3K is what I read. So swimming is extremely good. It works your whole body, works your legs, works your arms. It's great for the heart. Low impact. So swimming is great. Biking is in the same sort of vein. It's kind of a lower impact on your joints. So any sort of exercise you're able to do, I think, is actually it's pretty reasonable. I think that's all fantastic. The more you move, the better you're going to be. So Evelyn, I'll get to that in just 1 minute. So as far as how we do, so now we've gotten to the point where we have a disease, we understand the disease. Now we have to figure out what we're going to improve upon it. So when we talk to you guys about angiograms, so there's a different, there are different ways that we can kind of go about doing what we need to do. Our typical axis is in the groin, the femoral artery. So it's traditional, allows for larger devices. It's a bigger blood vessel. There's always the risk of, hematoma. There are times where you finish the procedure itself, you have like a little bit of pain right there from a really small incision because blood is an irritant. So you'll have like a little hematoma there that eventually dissipates. It takes about like 5 days, 5 to 7 days before it's completely gone. Maybe a little bit longer for those that have had bigger devices, and it varies, but usually about 5 days is how long it takes. Now, those that we can't use the femoral artery, suppose we have to come from above. And, I talked to you guys if we have to use the brachial artery, and in some cases, my partners use the radial artery. It's excellent for patient comfort. You can sit up immediately. When you do a femoral access, you have to lay down for a few hours to let the blood vessel heal. But it does require longer catheters and comes with its own pitfalls. And to kind of give you an idea as to what we're talking about, when you take a look at the femoral artery, it's down here by the groin, and that's where we are able to go backwards into the iliac vessel, into the aorta. You can effectively do the same thing for the brachial artery. Sometimes I'll do a cut down, a little incision of the brachial artery in the arm, and effectively be able to do similar pictures and be able to intervene upon it. But those are two separate things, or two separate ways in which you can approach it. And there's a lot of different ways to sort of do what needs to be done. But suppose that we get to the point where we have blockages. And so routine blockages or routine sort of like narrowing. Sometimes we get narrowing of the superficial femoral artery. That's easy enough to get, in most cases, get a wire catheter, be able to take your image, be able to balloon it. And in some cases, you need a stent. Where it starts to become a little bit more difficult is when you have things that are called chronic total occlusions. And so what chronic total occlusions are, it's exactly as described. It's a blockage, has a hard cap, very difficult to get through. And so this is where we start talking about the more advanced techniques that are available. So I think this is sort of one of those things to give you an idea. It's not always transparent as to what we do in the operating room. Routine things are being routine. Angiograms that are diagnostic where we just take pictures, pretty routine. It's just a needle poke. It's a sheath. We take our pictures and we're done. When we start treating things that we know that might have a chance of being treated, this is what we start talking about, chronic total occlusions. And so the way that we get around it, it's actually kind of an advanced technique where we're able to get around the blockage. And sometimes to get around the blockage, we have to sort of find a way for the wire and the catheter to get around the blockage, kind of on the outside of the actual cap itself, and then get back into the blood vessel. And so when we re-enter the true blood vessel, there are certain catheters and certain deployable mechanisms within those catheters that help with this process. Sometimes we're able to just do it with a wiring catheter itself, but in some cases, when we can't cross it from above, when we're going from the femoral artery down to the foot, sometimes we go backwards. So we start from the foot and go back up towards the groin. And so a lot of this is just, these are words. I think the pictures actually do it a little bit more justice in terms of giving you an idea of what we're looking at and what the ultimate results are. So, if you look on the panel on the left, this is in relation to the angiogram, that you see over here. These are the pictures. So this is just the diagram of where the blockage is. And it gives you an idea of where the wire and catheter would go in terms of the actual lesion itself. And once you're able to get the wire around the blockage and get back into the true blood vessel, what you end up doing is you're able to get around the blood vessel, make sure you tack up the wall. Once you're able to tack up the wall, then from there, you can sometimes place a stent or a stent graft, which is just, a stent that has a coating on it. And you're able to reopen a blood vessel that was otherwise closed. Another, picture sort of schematic of this is over here on the right, where you're coming from below, where you try to get across from the top. You can't cross it, and sometimes you come from the foot and get a wire catheter, and you're sort of able to make a guide. with, the catheter kind of crossing through the lesion, able to balloon it, and sometimes you're able to stent it. And then yet another, sort of like close-up of what we're talking about when we try to cross lesions like this, and sort of real-world results here on the right. Suppose you have a long segment that, is otherwise closed. So if you look on panel E, this is a superficial femoral artery that is pretty blocked. There's no blood flow going through it, but the actual lesion itself was short enough where we can use a wire catheter to get through it. And so same sort of principle applies. We're able to get a wire catheter, get into, the true blood vessel itself, be able to balloon it, and in some cases be able to stent it open so we could reestablish blood flow into a place where it was not going. So to that end, these are, shorter segments or shorter lesions that aren't always, you can cross them. You don't necessarily always do a bypass for things like that unless you get to a situation where you cannot stent it, where you can't cross it. So the rule number one here is, you'll see sometimes you go into the operating room, we say we're going to do an angiogram, possibility of some sort of treatment, and we can't. The reason is you can't stent across a rock. And sometimes in the event that we can't come across it, sometimes we try to modify it. And so when you try to modify it, that's the calcium within the blood vessel itself. So sometimes we're able to do it, sometimes we're not able to. But if we were able to, one of the ways that we go about doing it is you modify the actual calcium within the blood vessel with something that's called intravascular lithotripsy. So you guys are familiar with kidney stones. So the urologists will use a special device that takes kidney stones, especially ones that don't pass on their own, to break up the calcium to little tiny chunks, and that's how you're able to get rid of kidney stones in certain patients. In a similar fashion, the way that we go about sometimes treating calcium within a blood vessel, so we use a special sort of balloon. So it emits a lot of pressure in a very small space, and it takes something that if we were to balloon it by itself would crack and tear the vessel. What this balloon does, this specialized balloon does, generates a lot of force, makes little cracks within the calcium, and embeds it into the blood vessel itself. And so what it does, it minimizes the amount of trauma to the blood vessel and gives us an opportunity to expand the blood vessel. And we still have to do certain things like use a drug-coated balloon or place a stent to give you the best shot that we can to reestablish blood flow. But this is just a little schematic, and I know this presentation will be sent out at some point, but this gives you a very kind of linear idea of what we're doing in terms of placing the balloon when we expand it, what the actual, sort of in theory, what it's doing in terms of the calcium. It's cracking it, it's embedding it, and reestablishes a blood vessel that, although still diseased, still gives us a platform to expand it and gets the blood vessel to the point where it can get blood flow down to the foot in a much more effective way. So going from this particular therapy, what we often do, especially when we're able to crack the calcium, we're able to make the blood vessel a little bit bigger. Sometimes we use drug-coated balloons, and most of us do. So you use sometimes a plain balloon that doesn't have a drug. Sometimes we use drug-coated balloons and drug-eluting stents. And what these are, the actual drug itself, these are two very old cancer drugs. One of them, sirolimus, is still used, especially in transplant patients. But what these drugs do is they arrest cell proliferation. So they stop the actual cells on the inside of the blood vessel from kind of forming another scar. So remember what I said before, blood vessels don't like to be manipulated. What, we do in terms of any sort of ballooning or any sort of intervention, once you intervene upon it, once you expand, you crack the calcium, make the blood vessel bigger, then the blood vessel starts to scar. And once it starts to scar, you fundamentally have the same problem or worse. These drugs, paclitaxel, sirolimus, and the drug-coated balloons or the stents that they come with, will actually arrest the inside. They'll stop the inside of the blood vessel from forming more blood or more sort of cells or layers, and sort of holds the shape for as long as possible. How long they last, those are still, sort of studies that are ongoing. Usually the 5-year patency, so the 5-year window in which they stay open, is actually pretty good. Usually within the order of about like 60 to 70%. You still will have a problem at some point, but it buys you a little bit of time. And so all the trials that really led to what we're able to do for patients, instead of putting, metal stents, there's a trial that was run with the older, balloons that are still used. And there are newer versions. And so the actual data comes from the Medtronic impact trial. So this is the actual drug-coated balloon that was first used. There are many iterations from other companies, but ultimately what it came down to is if we did just a plain balloon, or if we just did a regular angioplasty without this drug-coated balloons actually have a long-term benefit, sort of a metal-free solution that is about the same, if not better, compared to just balloons or stents alone. And so we step away from that to things that are covered. So stents that, are not just metal, but actually have covering. So sort of like teeny tiny bypasses within your blood vessels. You use this when balloons fail. If you have, an area of narrowing or like tissue that just continues to scar or just kind of like rebounds like a rubber band. We use covered stents like to cover stents to actually expand upon it. And sometimes we use stents that have the drug coated to them, like I said, drug eluting stents. And usually it reduces the amount of like re-narrowing by about 40% to just, regular stents we just talked about. And so this is just a schematic little diagram that shows you a drug-coated balloon. It's like on the outside of the balloon itself. And what it does is when you expand the actual balloon to the inside of the blood vessel that you're treating, it kind of sticks the actual drug itself to the inside. And then when it sticks it to the inside of the blood vessel, it's absorbed. So it has like a little short window in which it can transfer into the blood vessel, but it's pretty effective. And then this kind of gives you the idea of what happens when we see an artery plaque ballooning and then stenting, what it looks like. In the same sort of way, if this stent has a drug attached to it, it does it mostly just exactly kind of like what we talked about with a drug-coated balloon, but transfers it there locally where that stent actually is. So kind of, rounding out and getting into the more advanced techniques, where does all of this information come from? Like, why do we do these things? This is not just random. So everything we do within vascular surgery is all very much data driven. So we see a problem, we study the problem. Once we study the problem, we publish what we have like found. And so one of the studies that was done, so concluded in 2022 and published in 2022, was if we were doing bypasses, how does that compare to those that need or that can tolerate endovascular or just through the blood vessel, so wires, catheters, and stents for those that have rest pain or tissue loss? And so those, and what this really concluded with is those that have good veins. So if you have a saphenous vein, like on the inside of your thigh, so you have superior outcomes, especially when you have tissue loss or rest pain. For those that have that, doing a vein bypass is the best. Those that do not have great veins, then doing some of the techniques that we've talked about and some of the more advanced techniques that I will talk about had equivalent outcomes within those patients. So that really led to the next set of studies. So there's another study called the Basel 2 that suggested that especially when you have patients that have really, really bad blood flow, so really bad rest pain, sometimes you can have a strategy where you do these wires, catheters, balloons, and stents that really help them. But those, and that's really for frail patients and those without veins, but still suggested that if you have a good vein, doing a good vein bypass is still important. And so what we try to do from here is we talk about, suppose that we need more complicated solutions for a more complicated problem. And that's where some of these more complicated and more advanced techniques come into play, because ultimately you want to be able to get the blood flow as good as possible. And sometimes it's not just one single segment within the leg, it's sometimes multiple. So this is just an image of what we actually do, where we actually do an angioplasty. Whenever we say we're fixing or cleaning out the femoral artery, this is the femoral artery where we actually take out the calcium and take out everything within the actual blood vessel that's narrowing it. And then we repair the actual blood vessel itself. And what we do from there, especially have not a problem just in the femoral artery, but suppose you have a problem in your iliac artery, so in your belly or in your aorta, we're able to use the wire catheter and go backwards into the belly. So the belly is over here where the iliac artery is, and then your foot is on the right side of the screen. So this kind of gives you a little snapshot without showing you too much of the way we will approach it when we do these hybrid techniques. And that really comes down to, suppose you're not having just a problem within the leg, but suppose you have a problem within the aorta itself or with the iliac arteries itself. Some techniques that we talk about is sometimes we do what's called a complete endovascular reconstruction of the aorta. And that's where, if you take a look on the right, where you have, pretty bad disease within the iliac, and you can see that on the left iliac artery, it's completely out. So you have, sometimes these patients would typically come in with, I can't move my left leg as well as possible, or I can't walk around, or it hurts my thigh all the time. So this is one technique that I utilize when appropriate. Another technique is doing kissing iliac stents. So suppose you take this little aortic piece away, and you have two stents that go from each iliac artery into the aorta to really open up the iliac arteries. The goal is, especially in those that can't tolerate a big open surgery, to do like an aorto bifem surgery. So you're able to get wires, catheters, balloons, and a lot of patience and some time to take this picture here on the left and turn it into a picture here on the right, where you're able to improve upon the blood flow so that you can get better flow into the femoral arteries and into the thighs and into the rest of the leg. In certain patients that cannot tolerate, for instance, a vein bypass, so fret not, there is an actual like solution for those patients that can't tolerate a bigger surgery. So it's called an endovenous bypass. There are certain criteria, certain things that have to be met, but suppose that you fundamentally need a bypass from your femoral artery to below this blockage, and you need a bypass in order to help things heal. There are ways and techniques where we can just use wires, catheters to actually make a bypass that goes from the superficial femoral artery, goes through your femoral vein in your leg, and re-enters into your popliteal artery. It's actually very, very effective. And I've used this in certain patients that have wounds that preclude me from actually making an incision, or those that are pretty frail that wouldn't tolerate longer periods of anesthesia. And that brings us to, patients that have, no relative options. Amanda. And Evelyn, I'll see these. Amanda, that's a good question. And they're considered hybrid techniques, especially when we do femoral endarterectomies. And so anything that's hybrid, when I say hybrid, that means we're doing a combination of open as well as endovascular. So anytime that you make an incision and you have to get access and you have to control the blood vessel itself, that's where it goes from just purely endovascular, just purely wires, catheters, to a hybrid approach where we have to make an incision on the artery or modify the artery itself to allow for more advanced endovascular techniques. So that's a good question. And Evelyn, I'll answer that at the very end. Okay. So the no option patients are those where we've tried everything and there are no targets. And historically, these folks that have what's called a desert foot, where you have no targets, you don't have any tibial vessels, there's no way to get from your femoral artery all the way down to the foot. Historically, those patients have had, about 100% amputation rate historically. And then tagging on to like the detour system and the whole idea of endovenous bypasses. Suppose that you don't have an artery that is a target. One of the things that we have recently started to study and really started to develop is the idea of what if we take the vein, especially down near the foot or, kind of like lower part of the calf, and we're able to put the artery and vein together, and you're using your vein as the artery. So you're basically rerouting high pressure arterial flow into the deeper veins in the foot, and it flows backwards and sort of does the same thing as what the artery was trying to do, but if the artery is too diseased. So we've basically made a brand new artery, if you will. And so that's the whole principle of, this new procedure called GlimFlow. It's something that we do open sometimes as well. And the whole idea is being able to take something that is no option, no way that, normally you'd be able to revascularize the foot, and then giving you a chance. And so to that end, the whole idea of deep vein arterialization, something that, again, the whole group is capable and has done, and we do, especially when there's no other option, is if you follow it from panel A all the way down to panel C, you're taking your tibial vessels, things below your knee. You're able to take an artery and a vein, and you make a fistula. So you create a artery and vein that are connected. And from there, you are able to sort of make a patch. So you have a place where you can attach a bypass to. And then in the process of making this vein and artery sort of contiguous, connecting them, now you've created a brand new way for good oxygenated blood flow to get down to the foot, which is actually kind of remarkable. And so this is an example of what this sort of looks like where we put the artery and vein together. And then if you look really, the meat of it is down here on panel C, D, and E, where once you've made this fistula of the artery and vein connected, you're able to do the bypass to this fistula in something that you had no options, where there are no arteries whatsoever that were in the foot that you could meaningfully use. Now you've at least given it a chance where you can get good oxygenated blood to the foot, really to help it heal. And as part of the, talking about the more advanced endovascular techniques, minimally invasive techniques, this is a company, Inari is the name of the company, but their technology is such that you're able to do the same sort of thing without doing an open surgery. And it's not always appropriate for everyone, but it is an interesting option that has come up that effectively does the same thing, using wires, catheters, and kind of, some fancy convention. So really what this comes down to, so I've given you a lot of information, and I think there's a lot to discuss, and I'm sure there are going to be more questions that come up. But really the takeaway points from everything, aside from the normal things that we talk about in the office about risk factor modification and some of the things we can do to kind of help you in a conservative way, is in 2026 going forward, we have newer, fancier, and I think like really groundbreaking technologies like preparing your vessel with intravascular lithotripsy kind of has changed the game in terms of how we prepare blood vessels to get better interventions. Drug technologies, drug-coated balloons, drug-eluting stents, they've become sort of the standard of care to prevent re-stenosis, to prevent that blood vessel from narrowing, especially when you're at a point where you don't necessarily need a bypass right then. And then the new frontiers of where you have dedicated hybrid procedures or dedicated endovascular procedures that are complex, that get us to the point where we can solve problems that were once deemed sort of unsolvable in patients that were deemed too sick to have more advanced therapy. So this gives us a lot of tools and a lot of ways to sort of give you guys hope and to discuss things that we might be able to do. And hopefully this brings a little bit of clarity, especially those that have seen me in the office, about sort of the pathway of how I think about things and some of the things that are at our disposal, not just me, but as a group. So I appreciate your guys' attention, and on behalf of not only my department, but the hospital, we appreciate your time. Thank you.
Thank you, Dr. Ali, and thank you everyone for joining us for this event. We will have another event next Sunday at the same time, so please join us if you can. And thank you all. Take care.